Now I'll be referring to the patient as AB for privacy, and she has craniopharyngioma. Craniopharyngioma is a benign tumor, and what benign means is that it's not cancerous. So since it's not cancerous, it can't be metastatic, and that means that it won't spread to other regions of the body, and that makes the treatment really easy, since, well, easier than if it would be metastatic. So that's really great for this patient that we had when the embryo is first developing, and that would be the region of the brain. But you can't really see it in this picture. Cellular and supracellular, though, is more simple, and the cellular is like right around this region right here. So the tumor would be above it, so that's why it's called supracellular. The permanent cure for this kind of tumor would be 80 to 90%, so that's really good odds. It usually occurs within the first 2 years, so the surgeon usually follows that patient really closely to make sure that it doesn't come back. The peak bimodal age distribution would be 5 to 14-year-olds and 50 to 75-year-olds, and in our patient's case, she was actually only 20 years old, so it was kind of out of the ordinary and atypical. You usually classify the craniopharyngioma as either adamantinotus, which is usually more in children and so pediatrics, or papillary would be in adults. And the difference would be that adamantinotus is actually, it comes from a Greek word, adamantinos, and it actually means enamel-like and hard. And that can be confused with adenomas and adenomatous, so that's more gland-like, so that's the difference right there. Craniopharyngiomas are usually diagnosed through neuroimaging, which would be an MRI scan or a CT scan. Some treatment options would be surgery, and that could be a craniotomy where you open up the skull and then you remove the tumor, or a transmonal surgery, which I'll elaborate on later. You could also do radiation therapy, and that could be proton beams, where it's actually a machine that emits proton knife or cyberknife, and in this case, it would be the cyberknife for our patient. And you can't have chemotherapy for a brain tumor like the craniopharyngioma, because chemo doesn't usually go up to the brain because it's difficult. The clinical presentation of a craniopharyngioma would be that it's slow growing, so if you detect it earlier, it's easier to treat since it's smaller. The visual symptoms usually are blurry vision and loss of vision, and that's actually one of the most common symptoms that a patient displays, and that's how you diagnose them. And also headaches are also common. They also could display endocrine abnormalities like growth deficiency in younger kids, amenorrhea in women, which means that you stop your menstrual cycle and you don't really have cramps or anything. And erectile dysfunction would be prominent in men. And there could also be other abnormalities, since every patient has a different background and a different case. Other symptoms could be depression, nausea, and vomiting because of where in the brain it may be at. The patient history in this case would be that she was a 20-year-old Caucasian female. She was a daycare teacher, and she is from Bullis, Nebraska, which is 20 miles west of the Grand Island. It's near the capital over there. And she has family history of hypertension from her dad. And on September 2012, she complained of blurry vision to her eye doctor, and the eye doctor found something on decompressing on her optic chiasm. And I think he referred him to a physician, or Dr. Tomes, the neurosurgeon, and they found a large complex cystic cellular and supracellular mass. And cystic is actually the fluid part of the tumor. She displayed amenorrhea, hypothyroidism, adrenal insufficiency, and hypopituitarism, since it was affecting her pituitary gland, since it's above the pituitary gland. And then on October 2012, Dr. Tomes performed a transfenoidal surgery on her. And after the surgery, she had to permanently take hormone replacement, which would be the hydrocortisone she takes day and night every day, since it affected her pituitary gland again. And she also takes Suboxone for her hypothyroidism, and that's another side effect of the surgery she had. And her vision improved, and she only has nocturia 1 to 3 times a day, so that's, night, so that's okay. And her headaches went away, so that was really good for her because it was really hard for her to focus. So the transmonal surgery, you would enter the nasal cavity with an endoscope, and once you hit the sphenoid bone, which is right here, the neurosurgeon would drill into that, and they'd get into the sphenoid sinus, which is right here, so they'd cut into there, and there'd be a pituitary chamber, and they'd remove that in order to get to the pituitary gland, and they'd cut the tissue on the pituitary gland in order to get to the tumor, and that's why it causes the problems with the hypothyroidism and adrenal insufficiency. And once they get to the tumor, they remove it with like the specialized instruments. And once they do that, sometimes they could have an option of grafting. And once you're done with that, you would just close up the incision and then put back the sphenoid bone into its place. And then the surgeon would just pack the nostril with gauze. And there are risks to this surgery, like meningitis, which is the infection of the brain, heavy bleeding, anesthesia reaction, so like an allergic reaction to that, or brain fluid leakage. But these are all treatable, so it's optimal for the patient. The consultation we had was in June 2013, so it was like early this month. The MRI showed a recurrence of a large craniopharyngioma with postoperative changes. So it came back. So after the surgery, it probably had remnants of the tumor still there, so it began to grow. But in this case, the cystic component wasn't, it didn't grow back that, so they didn't have to drain it this time. But it was mostly solid, and she still had amenorrhea, hypothyroidism, adrenal insufficiency, since, again, the surgery caused that. She complained of a left eye pain, and she told the PA that she took 9 ibuprofens for that. And that's really hard on her intestines and stomach because that's what the ibuprofen does. So he told her to back off on that, and he'd give her other pain medicines, other choices, so that it wouldn't be so bad on her body. She didn't have any blurry vision or vision loss this time, so it wasn't compressing on her optic chiasm. And the optic chiasm, it's actually where the optic nerves intersect. But she still did have occasional headaches because it was, again, growing. Dr. Gee recommended stereotactic radiosurgery, or the cyberknife in this case, for 5 fractions. In general, the cyberknife is just a robotically controlled stereotactic radiosurgery. And the reason why you would call it radiosurgery is because it's so potent into one area for treatment. It doesn't have a fixed head frame like it would for the gamma knife, which is also another form of stereotactic radiosurgery. And instead, we use a mask for the brain and head and neck cancers, so that to prevent movement, so that we wouldn't have to put in markers or anything, because that's really difficult to put into brains. And we would usually put the markers into like other areas, like the pancreas or lung. And it's only 1 to 5 treatments, so it's actually shorter than what a typical radiation treatment would be, which would be around 6 weeks instead of just 5 days. Some disadvantages of this cyberknife, though, would be that it actually takes a while before you can actually start, since it's so specialized. And there's also limitations, like it can't be less than 5 centimeters, and it can't be for skin tumors, and it can't be widespread because it's so focused. It can't treat a whole large area. We like to use the better imaging and the soft tissue that the MRI would display with the CT, since the CT shows more of a detailed planning. And once you fuse those together, it's kind of like the best of both worlds. And for her treatment plan, we had her do 25 gray and 5 treatments. And gray would be the measurement for the radiation dose that she receives. And this is an example of what a treatment plan may look like. She actually received like 101 beams to her head, I think. And in this picture, it's actually a brainstem pilocytic astrocytoma. So that's pretty interesting. So for the research data that I saw, it's actually limited because of how rare the craniopharyngioma actually is. But I'll show the sources later in the presentation. So 75 craniopharyngioma patients were followed over a 27-year period, and all of them had surgery on the tumor. at 10 years, 85% of them were still alive. So out of those 85%, the ones that received radiation therapy had an 84% of no evidence for the recurrent tumor. And the ones that didn't receive radiation therapy actually only had 42%. So it shows how beneficial radiation therapy would be paired with surgery. And this study shows that they followed 121 cases for 39 years, and they all had surgeries. And the ones who had a total resection actually didn't have any at 10 years, since you got a total resection and it's gone. But we usually don't do that anymore, because it actually usually has permanent damages to the brain, and you'd have permanent speech changes, and it's not optimal for us to use that anymore. But out of the ones who actually had a partial resection, 77% were disease-free paired with the radiation therapy, and only 38% were disease-free at 10 years for those who didn't receive any radiation therapy. There was some cases that we only used stereotactic radiation therapy, and it was 40 patients. And at an 8-year follow-up, 100% were disease-free. And I think that's more dependent on how many patients they had. Instead of earlier, we had 121 cases, so that's probably why it's so different. And then finally we had 46 patients who went through 51 courses of stereotactic radiosurgery, so that would be the gamma knife or the cyber knife. And at 5 years, 97% of them were disease-free, and 92% were progression-free. So that means that they wouldn't develop or shrink or grow. So basically, summary for her case, the patient we had, she'll always have a lifetime of medical problems related to the endocrine system, like her thyroid problems and the corticosteroids she'll have to take for that. She'll permanently have to take it for all her life because of the surgery she had. Again, she was a rare case since she's only 20 years old, and it didn't fit with the bimodal age distribution of the peaks at 5 to 14 and 50 to 75. She had a limited amount of side effects and symptoms since she was relatively healthy other than the tumor. Her chance of disease-free survival is at least 75 to 95% at 10 years based on the studies that I saw. And the benefits of studying her would be that it helps you understand more about the disease, and that you can know that there's not always that typical case. There's always those exceptions, so you always have to look out for that too. And that's actually a picture of the hydrocortisone that she'd be taking. Some interesting facts I learned about the craniopharyngioma would be that there aren't any stages, either recurrent or newly diagnosed. It also has a solid and cystic component. So the cystic component is actually a dark oily fluid. It's consistency of like motor oil. And we usually classify our patients into two categories, palliative and curative. And with our palliative patients, that means that it has gone too far for them to actually cure them, but we usually treat them for symptoms now, so it'd be quality over quantity of life for them. But for our curative patients, there's still a chance, there's like a window of being cured, so we treat them really aggressively. And the only cyber knife in Nebraska is actually located here at St. Elizabeth. The patients aren't radioactive when they receive radiation. Sometimes people have that misconception that you're radioactive if you receive radiation. But I also did learn that sometimes they, like the physicist would give some patients with thyroid cancer a radioactive pill, which would be iodine 131. And once they receive that, it actually doesn't remain in the body because it has a half-life of around 50 days. And once the thyroid cells actually soak up the iodine, the rest of the iodine is actually emitted through the bodily fluids. So you have like radioactive urine or sweat. And that's actually really interesting because I didn't actually learn that or even know that the physicists would calculate such things. I thought that was pretty interesting. And we all receive radiation, whether it be cosmic, electronic, or radon. And we actually receive around 340 millicuries of radiation per year. And millicuries is actually a measurement after Marie Curie, who discovered radioactivity, and I thought that was really interesting. I had lots of people work with me, whether it be Rob, Dr. Yi, Dr. Ward, Paul, Nicole, Leo, Michelle, and just basically the entire Radiation Therapy Center team. They helped me a lot with this project, and I'm really grateful to them. And also, here's some pictures with me and Dr. Yi and Rob. I spent a lot of time with that puzzle, so I guess might as well take a picture with it. And there's Leo when he was younger, in his younger days. Yeah, I just like to thank everyone. It was a really great opportunity. It was a great experience.